Good morning. Actually, it's good afternoon, class. This is our Wednesday, September 25th class. I had about half of you in class this morning, so there will be a few things that I'm not going over, but I will tell you so you can check them out a little bit closer. I'll be going over this stuff. Please take some notes. Some of this stuff will be on your test. The first thing is I have a couple announcements, and I want you to know. Let's see, so your VSIM is next week on October 2nd. That is Wednesday. We will be doing that in the Weary Center. We will start at 12:30. It is the same as a clinical day, so we will be there till 5:30, 6:30, 7:30, 6:30, 12:30 to 6:30, 6 hours, 7:30, 12:30, 7:30, because you have to have 7 hours of clinical. So that will be that one. And then I will have another MSN student there just to help us do some of that stuff. She won't be there for the whole time. And Tricia will also join us probably about 1:30 because she had some other things to do when we moved the class up a little bit. And the other thing is you have a Kaplan exam this coming Monday. Remember that your focused review is due by Sunday night, and the sooner you can get it in, the sooner I'll have it checked off for you. So do those as soon as you can. You have to do 2 of the focus exams for, I think it's called reproductive gynecologic or something like that. There's an A, B, and C. You only have to do 2. You can do all 3. I've had a couple students do all 3, and that's great too. So go ahead and do that. Let's see. We did that this morning. We did that. For those of you that weren't there, just so you know, we talked a lot about fetal monitor strips. There is a PowerPoint on Canvas on fetal monitor strips. Please go over it. If there's something you don't understand, please ask your clinical instructor, ask me, because there will be some questions on the next test on the fetal monitor strips. Okay, another thing is we talked a little bit about contractions, and I know I've talked about this in my group. I'm not sure if Tricia's talked about it, but you always have to feel a mom's tummy to know how strong her contractions are. Okay, so you can't just have a mom come in and tell you how hard her contractions are, and she's screaming and crying, and then she's 1 centimeter dilated. What that means is her contractions probably are not strong enough, they're not close enough together. So the way you tell is by feeling the fundus, which is, remember, the top of the uterus, and if it feels pretty soft, kind of like touch your nose, touch the tip of your nose. If it feels like the tip of your nose, it's probably a mild contraction. If it feels like your chin, feel your chin. That's probably a moderate contraction. And if you feels like your forehead, that's a hard contraction. And that's what we want those contractions to feel like, between this and this. Okay? If they're mild, they're just not going to do anything. So I wanted to get that out there. Okay? This morning we did talk about different fetal monitoring with the machine. And there's a few other ways that we can do it. I'm going to talk a little bit about them. The one is the electric fetal heart rate monitor, or it's abbreviated EFM. And that one is how most people get monitored. It is an external monitor. A lot of things will make it hard to hear the baby, like how big mom is, how small she is. They'll make it easier. How much fluid does mom have? Sometimes all that extra fluid, if she's got a lot of amniotic fluid, that'll muffle the heart rate. So, and then the machine doesn't always pick it up. Okay. So if you have trouble monitoring the baby, you can always put what we call an internal fetal monitor or a scalp electrode on. And I wish I had one, but I don't. And maybe some of you have seen it. But it's kind of in a long plastic tube, and it's a couple wires. And you do the vaginal exam, and then you put the little tube into the cervix, to the baby's head. And at the end of this tube is a little, it's kind of like starting an IV on an adult, but it's a little metal kind of thing that and I don't ever say this in front of parents, but you kind of screw it onto the baby's head. And it's just kind of in a little curly cue. It doesn't go a couple times around, just like a once time around. And you just like put it in the baby's head, and it goes right under the skin, just like starting an IV on an adult, and that gives us a really good picture of the baby. We don't lose the baby. We can monitor the baby. We get better picture of what the baby's heart rate is doing. So that's an option if they're hard. Now, nurses put those in, but you have to be able to, her bag of water has got to be broke before you can put one of those in. Now, a doctor can come in and put one in through a bag of water, but a nurse cannot do that. She can put one on as long as the bag of water is broke, and that's something you might want to remember. So that one. The other thing that could be helpful with fetal monitoring is called an interuterine pressure catheter, and it's an IUPC. And it also goes up in the cervix, and it sits right beside the baby up in the uterus. And it's a long tube, and what it does is it measures the pressure of the contraction. So if you have an external contraction monitor, that's the one that goes on top, you can't really tell how strong contractions are with that. That's when you want to know if it feels like your nose or your chin or your forehead. But if you put the internal monitor in, it will tell you exactly how strong those contractions are, because it measures the pressure that the uterus is giving when it contracts, okay, on the amniotic fluid. It sits right by the baby. The other thing you can do with that IUPC, and I think I'll talk about it later, is an amnio infusion, and somebody had one last week when we were there. So I think that's coming up in a little bit, but you use the IUPC to do an amnio infusion, okay? And then, so make sure I forget something, or don't forget something, excuse me. The other thing is a Doppler. It's a little machine about this big, and you can actually just place it on the mom's tummy and find the heart rate, and then you can actually count with your second hand on your watch the number of, you can just count and see. Or the other thing you want to do, you don't have to really count, but what you want to listen to is you want to listen to the baby's heart rate and see if you're getting fluctuations in the heart rate, because you'll kind of hear it. Or you want to know, like you want to be listening before, during, and after a contraction. So you want to listen before so you know what the baseline is, and during the contraction you'll want to listen, and then after the contraction. The most stressful time for a baby that's in utero is during the contraction, because and you'll notice it on the PowerPoint that we had this morning, and if you're just looking at it, as the contraction goes up, the amount of oxygen and reservoir for the baby to have oxygen, blood, nutrients gets kind of squeezed. So at the very beginning of the contraction, at the very end, is a great place for the baby to get all the oxygen it needs. As that uterus gets taller, they get a little bit less oxygen, okay? So if you're going to listen to a baby's heart rate, you always want to listen before, during, and after, so you can know, like, what's the baby been running? Does it have a decel after the contraction? Because for those of you that were there this morning, remember the decels that come after the peak of the contraction are the late ones, and those are the ones that are scary, that you have to worry about. The other thing, on that PowerPoint when you get there, there's a picture of a thing that says VL CHOP on it, and the VEAL on one side and CHOP, and it's just showing you how you can compare the baby's heart rate to what's happening on the heart rate. So like the V stands for variable, like variable decel, and then the C right across from it stands for compression, so cord compression, okay? And then the E under VL stands for early, CH, and H stands for head compression, okay? So the head's getting a little bit compressed, we see a vagal response, we see the heart rate go down, it mirrors the image of the contraction. And then A stands for XL, CHO stands for okay, baby's okay if you have XLs. And then the L stands for late decels, and on that little file, that little folder picture she's got, it says, I think it says acceleration, but it's really should be deceleration. So a late decel, let's see, late decel, and P stands for placenta. So when there's late decels, it means that there's a uteral placental insufficiency. So we're not getting enough blood and oxygen to the baby. Okay, so look at that veal chop thing. That might help you remember when you have to figure out which kind of one of these, what's going on with the decel that you're having. Okay, let's see, we went over those. So for the labor and delivery process of labor and birth, I put 3 videos on Canvas. Please look those over. I also on your Canvas have labor orders. So look those over because those are where you're going to get what meds can you give, can the mom be up walking, can she eat. It's all going to depend on who the doctor is, who the midwife is. And I know you guys are probably tired of hearing me say that, but a lot of times it depends on the healthcare provider that's providing care. Okay. Then true labor versus false labor. Oh, shoot, I need my book. Hang on, I'll be right back. So you should pull out your book and go to, go to page 425 in your book. Okay, I want you to look at that right now real quick because it's important. Well, it's all important. I think it's all important. It's probably not as important. You probably don't think that, but I do. So go to page 425 in your book, and right in the middle of that is distinguishing true labor from false labor. So how do we tell if a mom's in true labor or false labor? This is going to tell you. So, and this is kind of usual. So like a true labor, your contractions are going to be at regular intervals, and they're going to get stronger, progressively stronger, okay? If it's a false labor, they're probably going to be irregular, but not all the time. They can be. And they're usually not going to get more intense. So if it's false labor, the contractions are they'll either be irregular, or maybe they'll get regular, or then maybe they'll space out. But they're not going to be as strong as a real contraction would be. Okay? And then there's a pain. Which pains are they? The big thing that's a game changer for true labor versus false labor is true labor is actually going to change your cervix. She's going to dilate more. She's going to efface more. So those things are really important to know, the dilatation and effacement, and that'll help you decide. And that's usually what keeps the mom at the hospital. If she comes in and says, I've been up laboring all night long, and she's 2 centimeters and she's contracting every 2 to 3 minutes, and then 2 hours later you check her and she's still 2 to 3 centimeters, she hasn't effaced, and she's still contracting every 2 to 3 minutes, she may end up going home because she's not really in true labor. But we have to check a few other things. Does she have a UTI? Because maybe that's causing her contractions. Is she dehydrated? Because sometimes just being dehydrated can cause contractions. So you want to get an IV started and see if you can space those contractions out a little bit, because she'll not sleep that way, and then she'll come into real labor and she'll be tired. Okay? And sometimes with real labor, you'll look at this. It says activity such as walking usually lessens labor pain, usually. And lots of times with like false labor, Braxton Hicks, it doesn't really make a difference. Okay? Or it may, I said that wrong. True labor, the contractions get stronger and keep going and they start to dilate. With Braxton Hicks or false labor, walking doesn't make any difference. It doesn't speed them up. It doesn't make them stronger. It's just, they're just there. Okay? Let's see. Then go to page 429. And what you see on here is your labor and delivery admission record. So just so you know, so this is all of the stuff that we need to know as nurses, and it's actually 3 pages long. So because it looks at things like her history, pain level, allergies, everything you want to know when somebody comes into the hospital, only there's more labor stuff. And we ask them things like, did your water break? Did you have sex last night? Because sex will start labor up for them sometimes. Or if they're bleeding, did you have sex last night? It might have caused the bleeding. Is the baby moving? You always want to know if the baby's moving. So there's a lot of things that happens in OB that doesn't happen on the other general care floors. So just so you can kind of look through that and know. Then the stages of labor and labor support stuff, that is all in those videos I put online, so please watch them. And then, oops, I have to rearrange my seating area here. I'm sorry. You're thinking, oh, for gosh sakes. Let's see. I was going to show you on Canvas, there is a Friedman's curve. Can you see this? Okay. This is something we've used forever and ever. I don't know if I got it. 1955 it went back to. And what Dr. Friedman did was try to decide an average time limit for people to be in labor, whether they were a primip or a multip. So if you look at this, and this is on your Canvas site if you want to pull it up, if you're not there, but if you want to, it'll tell you, like, the first time mommies are the ones in the red. And can you see how that goes? The yellow's a little harder to see, I think, but the red one, first time moms, they take a little bit longer to get started, and then when they get up to about 5 centimeters, is that 5? Yep, about 5 centimeters, then labor usually progresses about the same until you get up to about 8 to 9 centimeters, and it takes them a little bit longer with their pushing, okay? So a second time mom is going to have this first little labor, and then once she gets to about 3 to 4, she's going to go zip and have a baby. So this is Friedman's labor curve. And this one was done in September of 2010. This is Zhang's labor curve. Honestly, I don't think this one has caught on because I never hear it talked about. I just hear about this one. Although Zhang's is something that the midwives talk about. So just kind of look these over, especially this one, because this is the one you're probably going to hear about if you get it on an NCLEX exam. Look this over so you know. Okay. Zhang's labor curve. And let's see what else I can tell you. True and Weber, mission. And then most of this stuff, like I said, is we talked about pain on Monday in class. So that's important to know all that pain stuff. Epidural things. Most of this stuff we got. There is more in your book besides the video that we had this morning on variability and stuff, so you can go ahead and look at that. I think that Rita did a really good job with, not Rita, jeez, what's the matter with me? I don't even know where Rita came from. Kim did a really good job teaching us about the different ways to read strips, and I'd like to have you guys know some of that stuff because I think there's a few test questions on it, just so you know. Okay, and let's see, that probably takes us to second stage, pushing. Just want to make sure we get all this stuff in here that we talk about. Okay. All right. So the other page I'm going to refer you to is page 461. If you can get to 461, I just want you to look at the placenta. So the placenta has two sides to it, as you can see. Okay, see if I can get this up here for you. Uh-oh, they're not going to see my, hang on, my machine's got to see that thing. Okay, so the placenta, this isn't going to work very well. Okay, you guys look at this, and I'm just going to talk you through it because my thing wants to keep turning because it can't find my little thing around my neck. Come back. Here, come here. Come on. No, you've gone the wrong way. I'll bring you this way. There we go. Let's see what happens with that. Hope she stays here. Okay, so if you look at this placenta, okay, it is a delivered placenta, and there's two sides. There's a fetal side and there's the mommy side, okay? So the fetal side is the one where the cord comes out of it. So that's the first picture, the fetal side, okay? And hopefully, me and Tricia can get you to see a real placenta. St. Elizabeth's keeps their placenta for 24 hours after delivery, and they should be back in the fridge. So hopefully you'll get to see that, and that's what I'm planning for my Friday group, is to go look at a placenta. You can touch it and do whatever you want with it, but yeah. Okay, and then the second picture is the maternal side. And this is the side that adheres to the, side of the uterus. So that's why it looks all bumpy and it's not nice and smooth like the fetal side, okay? Because it adheres, and that's what's got to pull off. And if you look right up above that, the third stage of labor is the placenta separating after the baby comes out and how it does. The big thing with the placenta and delivering the placenta is that you want to be patient. If you pull too hard on it or you pull too much on it, what's going to happen is your cord is going to break, or it might break at the insertion side. It might just break in two. And if that happens, that's an emergency because mom could bleed out. Remember, the placenta is still attached to her uterus, which is a big muscular organ. And remember, the organs have lots of blood vessels in them. So if you pull this off before it's ready or it breaks someplace, you may have mom bleeding out on you, and you don't want that. Okay? And then, let's see, we'll talk about that next week. Sticks of labor. Okay, we are ready for, and comfort we've already did, so we're going to just skip over chapter 13. If you have questions about anything pain-wise or comfort-wise in labor and delivery, please let me know, okay? All right, let's see what else. Oh, episiotomies and lacerations. Go to page 456. 456. Okay, so episiotomies are just like everything else. They come and go. Like for a long time, doctors routinely did episiotomies on women. Before they routinely did them, they let women tear. And then they decided that it was easier to sew up an episiotomy because it's a nice straight cut. So everybody started doing episiotomies at the very end when the baby was ready to come out. And then they found out that moms are suffering more issues with episiotomies, and that if you let the moms tear, maybe they don't tear as far as they would if the doctor did an episiotomy. So they let them tear, and those, even though they may be a little bit more complicated to sew up, they heal better because they were a natural occurring tear instead of somebody taking a scissors and cutting on the perineal area. So if you look on page 456 in your book, figure 1238, it shows you the different kinds of episiotomies. The first one you'll look at is the midline, so it goes right down from the vaginal area down towards the rectum. They should never be towards the rectum. Sometimes they tear into the rectum. That's called a 4th degree, and that's ugly. It's like mom probably should have had a C-section instead of a 4th degree tear or an episiotomy. The other one is a mediolateral, so you can see that one is just cut to the side of the, and those hurt worse. They burn more when moms go to the bathroom. They're painful. They take longer to heal. They're just like it, and we don't do them very often. You'll see those when moms have a really bigger baby and the doctors are trying to make more room. And that's why they do episiotomies, mostly to make room for the babies. And sometimes they'll do them because the baby's right there and the mom just can't get that last push in and she's tired and the heart tones are down. They may do an episiotomy to just get that baby out because they need to. But otherwise, if you were ever asked, letting a mom tear on her own is much better for mom's tissue. It heals better, all kinds of things. So having an episiotomy just is better, okay? Let's see. Then we'll talk a little bit about the umbilical cord. So we're going to go back towards the placenta, wherever that was, right here on page 461, that's where it was. So the placenta and the cord, you want them to stay together as long as possible. When the baby first comes out, the placenta is still in the uterus and it's still attached. Oops. It's still attached to mom, so you have the baby and the cord. So what research is showing us now is that if you hold the placenta down just a little bit below mom's bottom, that baby can get way more blood flow from that placenta that will make the baby healthier. Okay? It's called delayed cord clamping. So if the doctors can be patient and wait about 60 seconds, even 30 seconds is better than nothing at all. It used to be they'd pull the baby out and right away they'd clamp the cord and they'd hand the baby off to the nursery nurse. Well, now they get the baby out and they bring it down just a little bit below mom's bottom so the baby's getting a little bit more blood flow from the placenta through the cord into the baby. And then about 30 to 60 seconds, depending on your doctor, they can cut it and clamp it then. And instead of handing the baby off to the nursery, they give the baby to mom, which is what we want them to do anyway. If they wait that 60 seconds or so, it allows for about 50 to 100 cc's of blood to transfer to the baby from the placenta. Think of that. And it's not such a big deal for the for the moms that have nice healthy babies. But if you have a NICU baby that's maybe 28 weeks old or 32 weeks old or whatever, and you can get them 50 to 100 more mils of good blood from the placenta, that is such a boon for them. That is such a great starter in life for them to do that, okay? Okay, and then chapter 14, 12, 13. We're going to look at chapter 14. So these are complications that women have during labor and birth. So we're going to talk a little bit about those. And we'll start on page 505 where it talks about dystocia. Okay? And that's just a long or and we use dystocia a lot. We use like shoulder dystocia. We'll get to that with the baby. But this is a labor dystocia. It means the labor was long, it was abnormal. Maybe contractions were every 2 to 3 minutes, and then they had a 5-minute space, and then 2 to 3 minutes, or maybe they were once every 10 minutes, or maybe they were every minute of a labor contraction. So that's a dystocia. That's a dysfunctional labor pattern. And some of those, they've got some words for them. The first one is a hypertonic labor, okay, which means that the contractions are strong and they're painful, but they're not working. Like they're not changing the cervix, and that's what we want contractions to do. Remember, with contractions, the uterus contracts, causes a lot of pain, and if this is your cervix and this is the baby's head, when that uterus contracts, it pushes the baby down on the cervix, and that's what dilates it and effaces it, okay? So if you have a long, painful labor and your cervix is not dilating, that does a couple things. It makes you wonder if the baby's too big, if the baby's in there crooked, if the mom's pelvis is not big enough to deliver the baby through, or if she just isn't going to be able to deliver this baby vaginally. Okay, so you have to think of all those things. Okay. And on the next page on 506, it just shows you some dysfunctional labor patterns, and we've kind of already talked about those. The next one is a hypotonic. And if you just think about it, hypertonic and hypotonic, and for the students that were there this morning, do not get tachysystole and hyperstimulation mixed up with hypertonic and hypotonic. Two way different things, okay? So the hypotonic labor is when the contractions are farther apart. So like picture C on page 506, okay? So there's a few things that we can do with a hypotonic labor. Sometimes the doctors can just come in and break a mom's bag of water, and that's kind of the body's way of saying, oh, it's time to have a baby. I should labor better. If that doesn't work, we can start some Pitocin. That works. Sometimes we can use some Cytotec. That works. So it's all going to depend, here I go again, here, it's all going to depend on the doctor and the mom and what's going on as to which way they go. But a lot of times if a mom's in labor and she has like this number C thing where the contractions are so far apart, we're probably going to start PID on that and get her going. Okay. Okay, hypotonic we just talked about. And then if you want to talk about a precipitous labor, that's a labor that lasts less than 3 hours. Okay. So mom wakes up in the morning and she's having a few contractions and she thinks, I better watch this, and half an hour later she's having every 2-minute contractions and she feels pushy and she gets to the hospital and she delivers 30 minutes later. That's a precipitous labor, any labor that lasts less than 3 hours, okay, from start to finish. There's another one in there that you might want to think about. It is called a precipitous delivery. And the difference between that is one of them is labor and one of them is delivery. So a precipitous delivery is one that the mom was 8 or 9, now she's 10, and she just had a baby. Like, we didn't have time to get the doctor there. We didn't have time to get the room set up. Nothing got done because the delivery went so quick, okay? So precipitous labor and precipitous delivery, okay? Let's see, pelvic structure alteration. So you might have a pelvic dystocia where the pelvis is not shaped right, or it's too small, or maybe it's tipped tipped backwards. So then that's hard to get a baby out of there. And usually they can tell that stuff by ultrasound and by when the docs do their pelvic exams. So they usually know that kind of stuff when they come in. A soft tissue dystocia is where you're going to have, maybe you have a really big mom come in and she's got a lot of soft tissue that is just kind of going to get in the way and hold the baby up. A lot of times those people don't labor well either, and they end up being a C-section. Okay. Another thing to talk about is a trial of labor. And a trial of labor is bringing the mom in and watching her while you start some Pitocin on her to see if it's going to work. So you may do a trial of labor on somebody that's got a questionable LGA, or large for gestational age baby, to see if you can get her into labor, and if you make some dilatation and the baby starts to come down the birth canal, and if that works, you keep going. You may do a trial of labor on somebody that had a C-section the first time because the baby wouldn't come out or she wouldn't dilate, so you might try a trial labor on her just to see if you can get that baby to come down and she can dilate. Okay, trial of labor, I just mentioned VBAC, so anytime you think there might be a reason the mom can't get through labor and will need a C-section, you can do a TOL or a trial of labor. Okay? You still treat them like they're in labor. You monitor them. You watch them. You do vital signs every hour, half an hour, depending on what's going on. If a mom ruptured and she's been ruptured for a couple days and she's just having a contraction here and a contraction there, and they want to see if that baby will come down, you might do a trial of labor on that. Okay. An amnio infusion, I talked about that just a little bit. It goes through an IUPC. And if you look at, I don't know if they got a picture in here. I think they got a picture in here. But that IUPC that's up in there telling us how strong those contractions really are, you can add fluid into those, and you can actually run it on an IV pump, and you run fluid up into the uterus. And we do that for a couple things. One of them is for a mom that's got oligohydramnios, which is a tiny, not very much amniotic fluid. Okay, their AFI is low, which is amniotic fluid index. So, and remember what that amniotic fluid does. We did this last time. It cushions the baby, it cushions the cord, it helps. So we want to make sure they got enough labor, or enough fluid. So if they have a small amount of fluid, we may do an amnio infusion for that and add more fluid to it. If the baby has had a bowel movement in there and it's thick and it's green and you see it coming out of the vaginal area in chunks, which you might, we can add fluid in there, which helps to break up the BM content so it's not so thick, so that the baby doesn't get stressed out. Okay. If the mom's having a lot of variables, and remember what variables were? They were cord compression. So if the mom's having a lot of variable decels on the monitor, it might be because her fluid is low and there's not enough protection in there for the cord. So we may run fluids in for that kind of stuff too. So that's some of the things we do an amnio infusion for. Okay. There's also a picture of an amni hook on this page in 509. It looks like a big plastic crochet hook. I don't think I have one of those either. I wish I did. A big plastic crochet hook, and the doctor, and only the doctor can do this, or the midwife, goes up with that amni hook, like they do a vaginal exam, and they put the amni hook up there, and the end where the crochet hook kind of piece is, they just kind of grab the amniotic fluid and kind of snag it a little bit and put a little hole in it so that it breaks. Okay? Okay. And let's see, what else did I need to talk about? Dysfunctional labor we talked about. Hypotonic we talked about. Obesity we talked about. Other things that might slow the labor down are epidurals and pain medications. So if you put an epidural in too early, and I think I told you in class how we put an epidural in once for a mom who didn't want to have any contractions and she didn't want to feel pain, and we were starting Pitocin on her, and we used PIT all day long and she never did any dilation or anything, and we turned the epidural off and turned the PIT off, and after her legs came back we sent her home. If you put an epidural in too early, it will slow labor down. If she's in a good labor pattern, it won't so much slow labor down. It's when you put them in too early. If you give her pain medication, and the big pain medication that we use in labor right now is fentanyl. It's very good, lasts for, I think we've talked about this too, so it lasts for An hour to 2. I usually tell all of my moms that moms usually get about 2 hours out of this. Not usually. Usually they get a 1, but you kind of put that thought in their head, and sometimes it goes a little longer before they need pain medication. It doesn't always work. So epidural pain meds can slow labor. And precipitous we talked about. Labor. Pelvic dystocia we talked about. Soft tissue. Okay. So, and also on the soft tissue dystocia, that's things like placenta previa. Remember where the placenta has grown over the os, so the baby can't get out. If the mom has uterine fibroids, sometimes that will cause us a problem. The other thing that can cause a problem is a bladder that's full. That's why you want moms to empty their bladder every 2 hours, because if their bladder gets full, it gets in the road of that baby coming down the birth canal. Okay, and it slows labor way down. So if the mom hasn't gone to the bathroom in an hour or 2, I always make them get up and go to the bathroom and empty their bladder. Okay. Let's see, trial of labor we talked about. Amnio infusion. I just don't want to make sure I don't miss anything for you. Installation of oral saline. Amniotomy. Okay. The other thing that we do in labor is we do an induction of labor. So we induce moms to go into labor, and there's a lot of reasons for it. One of them maybe is that she's post-states. Remember, once they get past 40 weeks, the placentas don't work as well as they did before. So so sometimes we want to get them started in labor if they go that long. Other reasons are maybe the mom is a gestational diabetic or just a diabetic, and we've got a baby in there that's getting too big and we're afraid of her not being able to deliver vaginally. We may try to induce labor. The mom may be pretty insistent, and years ago we used to do inductions of labor anytime after 36 weeks. Well, what happened with those 36 and 37 weekers is they ended up in the NICU because they weren't ready to be born yet. Okay, so they had the last thing that babies mature up is their lungs and their breathing and stuff. So when we were delivering 36 and 37 weekers, and it wasn't us in Lincoln, it was nationwide. Everybody was doing it, 36, 37 weekers. Well, then AWON and ACOG came out with the 39-week rule, which was you should never do an elective induction before 39 weeks. So an elective induction and a needed induction are two different things. Elective is mom's tired of being pregnant. She wants to have a baby. Grandparents are coming in for the delivery. They've got babysitters. They've taken the day off of work, blah, blah, blah. Those are all elective reasons to have a baby. This one is for the medical reasons are things like the baby's getting too big. I'm not sure it'll come out unless we do it now. We've been watching your placenta on ultrasound. It's getting a little bit more calcification. Let's get you started in labor while the baby and the placenta are still in good shape. So there are medical reasons to be induced, okay? Bunch of different ways to induce. The first one is to just bring them in and break their bag of water. Sometimes that's all you need is to break your bag of water. Another medication that we use is called Cytotec or misoprostol. And that one is a little pill, and it's probably about this big. And you put in a dose every 4 hours until you get them into labor. It usually takes 1 to 2 doses. When we first started using Cytotec, the doctors would bring their patients in at night because it really wasn't made to put them into labor. It was more made to get them ready for labor. So what the plan from the physicians was to bring them in at night, give them a dose of Cytotec, let them sleep. In the morning, the docs would come in, break their bag of water, and they would go into really good labor. Well, what they found out when they started doing the Cytotec is that a lot of times that Cytotec threw moms into labor, so now the physicians are getting up at 2 or 3 in the morning to come in and deliver a baby. So we still have a few physicians that bring in a mom to have her Cytotec at night. A lot of them bring them in first thing in the morning and put Cytotec in, come over about noon, break their water, and usually have a baby somewhere in the late afternoon, early evening, sometimes. But like I've said before, everything's different for everybody in labor and delivery. So that's kind of a textbook picture of what they like to see. Trying to think if there's anything. So for the Cytotec, things you would have to watch for with Cytotec are uterine tachysystole, so you're having lots of contractions, and sometimes there's nothing you can do. If you get lots of, because once you put that little pill up, you put it up inside the mom's vaginal vault, right behind the cervix. You don't go into the cervix. So, and then it dissolves, and it's a prostaglandin, and prostaglandins help people go into labor. So once that pill is dissolved, you can't get it out again, but now you've got this mom that's contracting like this. So a couple things you can do. Get her up and empty her bladder. Start an IV and give her a bolus of fluids. Those are the kind of things you can do. We don't usually use a medication to stop that kind of labor, because if you let it go, it'll eventually wear itself out. So, yeah. So those are the big things. The other thing we use to do an induction is called Pitocin, which I know you guys have talked about. We use it before labor. We use it after labor. When you bring them in for a Pitocin induction, you start it at 1 milliunit an hour. Okay? And the hospitals in Lincoln do it the same, but hospitals throughout the United States will do it a little bit differently. So what we do at St. Elizabeth's is we use a 500 cc bag of fluid, and we put 10 milliunits of Pitocin in there. And if you remember back from your math quiz, when with that kind of a concentration, it's 1 cc to 1 milliunit. Okay. So, in your doctor's orders, Pitocin always gets charted in milliunits, and your doctor's orders are all in milliunits. And I think I might have orders in your chart for that. I'm not really sure. But, so the orders for Pitocin say start at 1 milliunit an hour and then increase every 30 minutes. Increase by 1 to 2 every 30 minutes. So you started at 1 milliunit, and then in 30 minutes you're going to increase it another 2 milliunits. So that'll be, now it's running at 3 milliunits. And in 30 minutes you're going to increase it to 5 milliunits, okay? Going to increase it 2 milliunits every half hour. What you're trying to do is get the mom into a good labor pattern. So what you're looking for, first of all, you're looking to make sure that your fetal heart rate is still good. We've got variability. We're not having late decels. Maybe we're having an early, who knows. And that your contractions, we want contractions not any closer than every 2 to 3 minutes. Okay? So you need that little bit of space between when there's no contraction for the baby to recuperate and the placenta to recuperate and mom to recuperate and get that oxygen and blood flowing again. We talked a little bit about that. Okay. Another thing that we've used in the past is Prepidel gel, and I think that's making a comeback. It doesn't really work that well, but I think it softens up the cervix so that when doctors do come in and break the bag of water, labor goes a little bit faster. The ARM we talked about. On Pitocin, again, go back to that. That's a high-risk medication, so you should never start that without another nurse telling you, looking at it with you. Also, I keep losing my train of thought. I got to quit that. So it's a high-risk medication. It is always, always, always on a pump. You'll never run PID in without it being on a pump. Okay? And if you look at page 514 in your book, it's going to give you some nursing considerations for when you're doing an induction for mom. Okay? So patient vital signs, when they're on Pitocin, you're taking a blood pressure every 30 minutes. Okay? You're listening to babies are on the monitor continuous when you have them on Pitocin. You're going to chart your contractions, your strength, your duration, all of that stuff. You're going to check her once in a while. You always want to chart your oxytocin infusion or your Pitocin. Okay? And anything else you see that's out of the ordinary. But because PID is high risk, you're going to be extra careful of what you're doing with that mom. Okay, then we're going to go to assisted operative vaginal birth. That's on page 516. And what that means when it says assisted operative vaginal birth is mean that the doctor helped the baby come out either with a vacuum extractor or with forceps. There are pictures of forceps on top of page 516. And There are not too many doctors in Lincoln that use them anymore, just because the vacuum extractor is a softer material. It works. I don't know if it works any better, but you have to really be trained to do forceps. And what I'm hearing is they're not really training. Like family practice doctors used to do forceps, and now none of them do it anymore because they're not training them to do it. They train them to do the suction, the vacuum extractor. Okay. I don't know if they got a picture of the vacuum extractor. Oh, on page 517 is a vacuum extractor. So down at the bottom just shows you like the little machine, and usually the nurse holds that little handheld machine, and we can look at that when we're in at St. Elizabeth's. And then the tubing is in this little white package. It's hard to see, but if you look at the picture at the top of 517, that little suction cup goes right on the baby's head. Okay, and then the nurse takes this little handle thing and she pumps up the suction to a certain degree, and in the picture, and you can see it when we get there, there's like a little green it's a little green markings on the little round thing with the numbers on it to tell you how high up you can go. This is really technical, I can tell. So, and then you hold it there, and when the mom has a contraction, she still has to push, but the doctor's going to be pulling on that suction cup a little bit with the baby. Okay. Same with the forceps. Once those forceps are in place, the doctor's going to pull on the forceps to help the baby come out, but the mom also has to push. She has to continue to push. He can't do it on his own. I did put a video up of both the forceps and the vacuum, so please watch that. It's on Canvas. Okay. Things you look for on a baby after this. On a baby with forceps, you might find some little red marks on the side where the forceps went. Sometimes you'll see a whole little red mark that goes like that. Okay. You're going to just look to see if there's any broken skin or anything. The same with the vacuum, only the vacuum's going to be up here. So you're going to look for like a reddened, maybe some reddened area, maybe some torn skin where the vacuum really tore. They're not really rough, but a lot of it depends on the docs. Okay. Let's see, forceps, vacuum. Complications associated with placenta is next, and that's on page 527 if you want to head there. Some of this stuff I'm skipping over, like the external cephalic version that's in here, because we saw a video on that in class. Okay. So where are we at? Complications with the placenta on page 527. Okay. So things can happen. A nuchal cord is something that we see so much of. I bet half or more of the deliveries have a nuchal cord. And all a nuchal cord is it's kind of wrapped around the baby's neck. Maybe it's wrapped around an arm when the baby comes out. Remember, the Wharton's jelly will help keep things protected. Depending on how tight the nuchal cord is, sometimes they can bring that baby out and slip the cord over the long part of the body, and it's really hard to see without really being able to see it. And or sometimes the cord is so tight that they can't do that, and what they have to do is clamp it while it's still in mom and then cut the cord so they can just get rid of it and pull the baby out. So the nuchal cord is just something you want to kind of keep an eye on. The other thing that you can see with a cord is what we call a true knot, and that's actually where the baby had been floating and swimming around so much that he actually tied his cord into a knot, which is amazing, but they do it, and it's always exciting when you can see one. Okay. Amniotic fluid complications. We talked a little bit about oligohydramnios when there's not enough fluid. There's also a polyhydramnios, or in your book it calls it hydramnios, but the other word for that is polyhydramnios, which means there's a lot of amniotic fluid. So in those cases, sometimes you won't be able to hear the baby's heart rate because there's too much fluid. We have had patients that have a lot of amniotic fluid, and usually it's the maternal fetal medicine specialist that comes in and puts a needle in her tummy and drains out some of that fluid. And I know we've talked about this in my clinical group. I don't think we talked about it in class, but they drain out some of the fluid, sometimes 500 to 1,000 cc's, and the mom keeps making it. So that's an issue. It doesn't happen very often, and it's usually with some kind of syndrome that mom has. Okay. Meconium is when the baby, and we talked a little bit about this too with the amnion fusion. Meconium is when the baby has bowel movement inside the uterus. And there's really nothing we can do except watch that baby on the monitor. It used to be years ago, if the baby had a stool in uterus, we wouldn't let them breathe until we got them under the warmer and we could suck out their nose and their mouth. Well, now if they come out and they have meconium stained fluid, what we do is see if they get vigorous and if they're going to like cry and wiggle and stuff. If they do all that, we just leave them alone. If they don't do that, then maybe they'll put a trach tube down and they'll suction out the nose and the throat and everything if they have to. Most of the time anymore, they don't have to. Okay. Complications with the placenta. And the other day I was trying to tell you about placenta previa, and I did find a picture that I had left over here, and I just want to show it to you today. I hope my thing will let me do that. So this is a placenta previa. Well, it's not all placenta previa. This is not going to let me do this again, I think. But if you look at this one, I have to get these right. This one right here is normal. So the placenta is built up at the top of the uterus and the baby's going down the bottom. Okay, easy to see. The second one is a low implantation, or marginal, I think is what your book calls it. Okay, so it's down kind of by the os is where your cervix is, but it's not really covering it. So the baby maybe could be delivered. It depends on how far up it's sitting. The next one is a partial previa, and what that one does is pretty much cover at least part of the cervix. So the baby can't be delivered vaginally with that one. And then the last one, let me come over here, is a complete placenta previa. So it covers up the whole os, and that one's a C-section too. Okay. Just wanted you guys to see that because I didn't have it in class the other day and I wanted to. Okay, so we talked about placenta previa. The other thing that I've mentioned before, and I know Kim mentioned this morning, is that placentas are made for about 40 weeks, and then they start getting calcified, and they don't work as well, and the baby doesn't get the blood and the fluid. So when they get to about 41 to 42 weeks, that's kind of a cutoff for even the midwives to get the mom in and get them induced. You know, you always have to think, oh, did we get the date right or didn't we get the date right? But probably the date is right, and you will see it on a monitor a lot of times. Okay. Let's see, placental abruption, we talked about that, so I'm not going to mention it. Just when the the placenta tears away from the uterus. Very, very painful. Remember that the abruption is different from a previa because the abruption is painful. The previa bleeds, the abruption bleeds, but the abruption is the one that hurts. That's the one big, huge symptom between the two that should tell you the difference between them. Okay. DIC, one of the students talked about that, so we're not going to talk about that. Rupture of the uterus. We had one of those in my clinical the other day. The mom ruptured her uterus in a T shape, so it went up and then like a T, and those are really hard, and she'll probably never be able to have a vaginal delivery. I don't know if her doctor will even let her get pregnant again. We'll have to see. Okay, because when you do a C-section and you cut the uterus, you cut from left to right, and you're cutting right along with the muscle fibers, so everything grows back together well. But if you cut up and down, you've just now cut into the muscle fibers, not the way they grow, but the way they don't grow. So now it's going to take it longer to heal. It may not heal as strong as a cut like this, okay? Or like this. I should do it this way so you can see what I'm doing, okay? So rupture of the uterus is kind of, it's an emergent situation, and if you don't get the baby out, the baby will die, and mom might die too. So just some things to think about. Let's see, uterine inversion, and this happens a lot when the healthcare provider, like the baby's out, and they're pulling on the placenta, trying to get it out, and instead of the placenta letting go like they want it to, what it does is it just pulls the uterus and turns it inside out, and out it comes. Okay, that's an emergent thing too. I saw that happen once, and it was a midwife, which was kind of hard to believe, but it was a midwife. And what she did was she took her fist like this, right in the middle of the uterus, and pushed it all back up inside the mom. And then she had an OB come and check to make sure everything was okay, and it was. And I don't know what happened after she went home, or if they had to do any other work on it or whatever. But if you pull too much, you can pull that uterus right out. And like I said, I've only seen it one time. Okay. Let's see what else we got. Uterine inversion. Umbilical cord prolapse is another thing to think about. So this one is going to go back to when mom's still pregnant, and the doctor comes in and ruptures the bag of water. As that bag of water just swishes out of there, sometimes that cord can come right down with the bag of water, as it's coming out. And when that happens, like if this is your cervix and your cord goes like right into the cervix, and then your baby's head comes down and pops right on top of the cord, what's going to happen to the baby? What's going to happen is that the baby is going to shut off all food and oxygen supply, blood and oxygen supply to itself from the placenta, because it's now acting as a cork, and it's smushing the umbilical cord. Now that doesn't happen very often when doctors break a bag of water. What they have to make sure and do is they have to make sure and check the mom first and make sure that baby's good and engaged down in the pelvis, that it's not like if you touch the baby and it floats away. That's called ballotable. The baby ballots out of the pelvis, out back into the uterus, which it can do. And because it's so big, it doesn't go that far. But if it still is ballottable, you're not going to break a bag of water, because those are the kind where the cords will come down first. Sometimes when mom's at home, if their water breaks, we have them come right in, because if the cord came down, sometimes they won't even know it. Or we have had moms come in and say, I think my water just broke and something's hanging out of down there. Well, then we have them come right away. Okay? If that happens, it's an emergent situation, and what you will see, you probably won't see it, and about the time I say that, you will see it. But the nurse will do a vaginal exam and hold that baby's head up off of the cord. So while they rush the mom back to do a C-section on her and get that baby out of there. So they're rushing down the hallway in the bed with the nurse in the bed with the mom, her fingers up inside the mom in her cervix, holding the baby's head up so the cord has room to just sit there and free flow blood like it's supposed to. And she stays that way under the sheets and everything with the patient while they drape her, and that she does not ever take her hands out of there until they pull that baby out. So they do a C-section with a cut above in the tummy, and the nurse is down here with her head, with her fingers on the baby's head, holding it up off the cord. I know, I've only seen that a couple times too, but it's enough to scare everything right out of you. Okay, and there's a couple pictures on page 531 of what a prolapse cord looks like, so you can kind of see what I'm talking about. Okay, and then let's see. There's some other cord things in here. I can have you read about them. I don't think that they're going to be things that you really have to know, but I would want you to read them. Okay? The other thing, go back to the prolapse cord, the other thing you can do, and this is page 532, is showing you pictures of the nurse with her hand on the baby's head holding it up there, or the baby's feet, whichever's there. The other thing you can do is put your mom in this laying down position or with her butt up in the air, because that gets the baby off the cervix too when they do them those ways. Okay? All right, what else we got here? Let's see, complications of labor. So complications of labor, fetal malpresentation. So the baby's coming down the wrong way. Maybe it's coming down breech. Maybe it's coming down with its feet first. Maybe it's coming down, we call it, like maybe it's coming down with the shoulder first. Or maybe it's coming down with the face presentation. So what you see when it's coming down is you see the face presenting. And that part of the head does not mold to the mom's pelvic area. So they usually can't deliver with the face presentation. They usually have to be a C-section. And a lot of times they know that by the time they get there. If the baby's coming down crooked, because sometimes they do, they come down a little bit with their head cocked to one side or the other and they can't really get out that way, the best way to fix that is to reposition mom over to your left side, over to your right side. C-section might be the next thing if the baby won't come out. Leopold's maneuver. Remember Leopold's? We talked about that, I think, before the last test. So that's where you feel the mom's tummy to see how you can, if you can feel where the baby's butt is and its head and all that stuff. There's also a issue called shoulder dystocia, and that's when the baby's head comes out, but now the shoulders won't come out because they're too big to get out of the pelvis. So now you have this head hanging out and these shoulders stuck inside mom. Okay, there's a couple things we can do. First of all, you may see your nurse pull a stool out from the closet, and that's just to stand her up at the bedside and get her up higher than the mom. Okay, that's the first thing. The next thing you do is you could put mom into what we call a McRoberts move. That's where you lay the head, she's pushing, we've got the head out, can't get the shoulder, so you lay the head of the bed down flat, okay, and then you bring both of her legs way up, as far back as they'll come, and if she's got an epidural, they're going to go clear back up here, and that opens up that pelvis so that baby's got room to get the shoulders down, okay. The other thing that you can do is, I have to remember how this all went. Let's see, the McRoberts move and that. The other thing some of the doctors have done is they can stick their hands, like if this is a cervix, they can stick their hands in there and kind of push down on the shoulders and see if they can turn them. Okay. The other thing the nurse can do is called suprapubic pressure. And I don't know if I'm going to be able to do this, but she gets up on top of her stool and she's above mom, and she takes her, she has to look at the head because she wants to get on the outside of mom where the shoulder is, and she takes her fist and she pushes, and what she's trying to do is move this shoulder in like this so it'll slip under the pubic bone. Okay. It's an emergent situation too, because now you've got this head out and these shoulders hanging there. The other thing that I've never seen done, and I hope to God I never will, is the physician can go in, because the baby's bones are not really hard bones yet, and he can break the collarbone so that the baby can be scrunched up and delivered. So, and I've never seen that happen, and I hope to God I never do, but it could happen. Okay, so that's shoulder dystocia. Hands and knees will sometimes help that. Squatting, the birthing stool, we've talked about that a little bit. Any of those different positions will help, okay? Then you have like a cephalopelvic disproportion. That's where the baby's head is too big to come out of the mom, okay? So cephalopelvic, cephalo is head, pelvic is the mom, so they have a disproportion. Baby's too big for the mom, okay? It's sometimes difficult to predict. Sometimes they can tell by ultrasound. Sometimes those moms get a C-section. Sometimes they should have and they didn't. So it's just always hard to tell. Multiple gestations, twins, triplets. I have delivered twins vaginally. I've delivered one vaginal twin and one C-section twin. I've delivered both twins, and not me myself, but I've been the nurse in them. I've delivered both twins C-section. So when the mom comes in to have her twins, if both babies are head down, and we may have talked about this, or maybe I did it in clinical, if both babies are head down, they can try to deliver them vaginally if that's what the mom wants. So what happens, you have these two babies with their head down, the first baby comes out, and then all of a sudden this baby here has this whole uterus to swim around in, and sometimes it floats away or it doesn't come right down. So the doctor, first of all, has to be patient, because the mom's going to continue to contract with the baby in there. Doctor has to be patient. Sometimes you will see them, okay, baby's head's here. Sometimes you'll see them do a vaginal exam and come in and try to bring the baby's head down or turn it into a position we want, okay? So that can be done. If one baby is vertex and the other one is butt, they'll deliver this one, and then a lot of times the doctor will take his hand and arm in there and go in and try to turn that other baby so it comes down head first. Okay? If they're both butt, they get a C-section, and there's no ifs, ands, buts, or maybes about it. If you have two babies that are vertex, what they do is when mom gets ready to deliver, everybody goes back to the C-section rooms, and they do a vaginal delivery in the C-section rooms. And that's because if the first baby comes out and the second baby needs a C-section, we don't want to waste time trying to get the mom back there. We're already back there, and the surgical tech, who all of you have met, we'll have the room set up both for a vaginal delivery and have everything pulled for a C-section. So just in case the second baby doesn't want to come out. Always, always twins. Triplets, quads, I've never seen any of those delivered vaginally. They were all delivered by a C-section when I've seen them. Let's see, we talked about that. Non-reassuring heart tone patterns. We'll go back a little bit to heart tones, and I know Kim went over some of this morning. If you have a non-reassuring heart tone pattern, and that would be like late decels, the first thing you're going to do is reposition mom to her side, get her off her back. Increase the IV fluids, the control IV. If you have Pitocin running, you want to turn off your Pitocin. If you, let's see, reposition mom, turn off the pit, put oxygen on. And at St. Elizabeth's, we use a non-rebreather mask, and I think it's 10 liters a minute for a non-rebreather mask if you have bad decels. If you turn, and the books all say to turn them to their left, and I say start with the left. If it don't work, you go to the right. You got to just turn, and you may turn them to the left and that don't work, and then you turn them to the right and you think you got it and that don't work, and then you turn them to the left again and then it works. So you may be moving and turning, and you always want help in there when you have bad heart tones, okay? So increase your control IV, oxygen, left or right side, turn off the pit, anything that can help the mom, because remember we talked about contractions. The most stressful time for a baby in a contraction is at the peak of the contraction. So if you're making mom have more contractions with Pitocin, then you're causing more problems. So if the baby's having bad heart tones, you want to turn off the Pitocin to start with. It gets out of the system very quickly, 15, 20 minutes, even less than that. Okay, and you're giving them a control IV, you're flushing their fluids with the control IV, so that'll help get some of that out of their system. Okay. Let's see, I think we talked about all of that. Prolapse, amniotic fluid, cesarean, perinatal loss, amniotic fluid embolism. Cesarean birth, when they have to go back for a cesarean, there's two types of cesarean birth, and I think there's a video on Canvas for this, but one of them is an elective because I had a C-section last time, and the other one is because we have fetal heart tone problems. So if they're elective, I had a C-section last time, I should do it again this time. They come in the morning, they have a scheduled time, they can get off their days of work when they want, they know exactly when things are happening, grandparents can come in, they have their C-section, you get them ready for a C-section, you start IVs on them, you do a little bit of a shave prep down there for them, you give them a prophylactic antibiotic, which is Ancef. Everybody gets that unless they're allergic to it. And you have them sign a whole bunch of, they sign permits for themselves and for the baby to be treated at the hospital to have a cesarean section. Anesthesia comes up to talk to them, and then they walk back to the C-section. They usually get an epidural or a spinal, depending on anesthesia. We do not do a general anesthesia because that's for an emergency only. Like if you have to get that baby out right now, a general anesthesia takes about 2 minutes to set up. Okay, and once you've got general anesthesia on board, you want that baby out within 4 minutes. And I think we've talked about this someplace in class. I can't remember. Maybe it was clinical. But anyway, so it's very quick and easy. Depending on your doctor, the baby can be out in 10 to 15 minutes or 20, depending. Then they spend about a half an hour, 45 minutes in the recovery room, and then they go to postpartum. They have a dressing on their abdomen. They get a little incision about this big. Okay. And usually it's like what we used to call a bikini cut, so it's very low, and they won't be able to see it like with the swimming suit and stuff. That's why they called it a bikini cut. There's an incision on the skin, and there's also an incision on the uterus. The one on the uterus, we like it to be sideways. Remember that we talked about that earlier, from side to side. That cuts with the muscle. If they're in a really big hurry, they may cut the uterus up and down, and if they cut the uterus up and down, those patients will forever have a C-section because the muscles do not grow back strong enough to tolerate another labor. Okay. Let's see, C-section. They stay in the hospital a little bit longer, usually 3 days. A vaginal delivery is 1 to 2 days, usually 2. So, and we watch them a little bit closer. Vital signs are a little bit done. The fundal checks that you guys have all been doing, we do them on C-sections too, and they don't like it. They like it way less than even the vaginal deliveries, but it's one of those things that you call a necessary evil, because if you don't do it, they may hemorrhage. A C-section mom will have a Foley catheter till the next morning. She'll get that right after her anesthesia has set up. And I don't know that there's anything else really that I want to tell you. When she has a C-section mom will go to her room, and at both Bryan and St. Elizabeth's they do mother-baby unit now. So when she goes back to her room, the baby will go with her, but she has to have somebody in there at all times for that first, I think it's the first maybe 8 hours or 12 hours, so that if the baby needs to be picked up or something happens to the baby, somebody else can help her with that, because she's not going to feel like it right away. And if she still has her epidural on board or her spinal, she won't be able to stand at all. Okay. Let's see, page 537 is where they talk about C-sections. So I would go through and look at that stuff. The thing with C-sections, elective C-sections are one thing. A necessary C-section, because now all of a sudden your baby took this big dump and you can't get him to come back up. That's a scary time for mom. First of all, and dad. First of all, she's worried about her baby. And second of all, when that happens, you have a whole room full of nurses just like packing into her room. They're shaving her. They're giving her meds. They're changing out her, getting her off the monitor. They're rushing her down the hall. She gets scared really easy. So one thing that nurses need to remember is to just take a few minutes and say, I'm here and I'm not going to leave you. I'll be right with you when the baby's born. The baby's going to do fine. Always reassure her about the baby, because that's the big thing. Okay? Let's see. On page 539, it just shows you some of the cuts that I had just talked about. The vertical and transverse. Transverse is the one we usually want. Okay? The low transverse, it looks kind of like the transverse, but okay. So the top two are on the skin, and they usually do the transverse on the skin, and then the bottom three are on the uterus. And there's some pictures of a C-section on page 541 if you want to see that. And let's see if we're different. Incision, page 539. Who did that? Okay. And then the only other thing I think I've got left to tell you, and you're all thinking, oh, thank God, is a post-term pregnancy. And that's when it gets to be 40 weeks. And it's considered post-term and post-dates. And by then, there is a picture on page 544 of calcification of the placenta. You can see all those little white spots in there. So as the uterus gets more calcified, less blood and stuff are going to flow. So they're going to want to get that baby out of there. So there's a lot of reasons to do an induction for those kind of people. So I think that's it. But if not, I will send you an announcement. I can't think of anything else I really wanted to tell you. I told you about VSIM next week, Kaplan on Monday, and I think that's it. For my clinical group, please bring your red folders with you when you come on Friday to class, and I will see you all next week. Have a good weekend.